Good evening, ladies and gentlemen. You'll pardon the croak in my voice. I've been traveling a lot, and in the last few days I've had a cold. My grateful thanks to all of you for being present this evening. My thanks to the Romanian Rheumatology Society, and particularly to Professor Rednick for this kind invitation. It's a great pleasure and a privilege to be speaking to you tonight. Now, those of you who've been here since the morning have had a long day of science and medicine. I'm going to take you in a slightly different direction on a journey that all rheumatologists, I think, should enjoy. And I hope that at the end of the talk, you will find it worthwhile. And I've titled it Looking Back in Wonder, a century of brilliance and serendipity in the treatment of rheumatoid arthritis. Now, serendipity is good luck or good fortune when we make a discovery. A classic example is Alexander Fleming finding the penicillin notatum mold, and that led to the discovery of penicillin and that changed the world forever. So I would like to quote Carl Sagan, who was a visionary thinker and an astronomer, who said, "You have to know the past to understand the present." So those of you who have grown up in the post-biologics world will not probably realize that it's been a long journey to get where we are today. And the journey starts almost 130 years back. And when I speak of serendipity or good fortune, Louis Pasteur said, "Fortune favors the prepared mind." And in rheumatology, there has been individual brilliance, but also these strokes of luck that I will try and relate to you as we go along. So arthritis of various kinds is a disease of antiquity, even prehistory. There are remains in Egyptian mummies, in burial sites in North America, which show evidence of arthritis. But the timeline of our talk today would be from the late 19th century to the present, and particularly focusing on the last 20 years. But before we go down that path, I'd like to mention three people. First of all, William Heberden, who actually made the distinction between gout. All kinds of arthritis were thought to be gout before then, and he obviously described what we now know as nodal osteoarthritis. But it was about 100 years later that Sir Alfred Garrod coined the term rheumatoid arthritis, and then across the Atlantic in the early 20th century, an American Goldthwait made the distinction between osteoarthritis and rheumatoid arthritis. I live in a small village which is on the outskirts of Birmingham, and it's not too far from the small town of Stratford-on-Avon, which is the birthplace of Shakespeare. And a few years ago, we celebrated Shakespeare's 400 years. And I'd like to frame this talk in the context of Shakespeare's plays. So Act 1 will be non-steroidals, then we'll go on to Act 2, which will be disease-modifying anti-rheumatic drugs, then biologics, and lastly, JAK-inhibs. And finally, the curtain will fall on what we think the future is. This will be peppered with other observations around developments in our basic understanding of the immunopathogenesis of rheumatoid arthritis, the advancements in trial design, imaging, the development of multidisciplinary teams, as well as the development and evolution of patient advocacy. And last but not the least, the concept that is so dominant in our thinking around inflammatory arthritis, which is to target low disease activity and remission. So Act 1, non-steroidal anti-inflammatory drugs. The late 19th century was a very, very important period in all fields of human endeavor: politics, social change, science, and of course medicine. We had Robert Koch isolating the viruses in his laboratory, and there was a long period of thinking that rheumatoid arthritis was a result of an infection and hence the use of heavy metals in its treatment. But it was in 1897 when this dapper young pharmaceutical chemist, Felix Hoffmann, working for Bayer, the giant German chemical plant industry, who synthesized acetyl aminosalicylic acid, or aspirin. Now, it was known for several hundred years. In fact, there was an English priest called Edward Stone who used to boil willow bark and give it to his patients for fever and joint pain. And the active ingredient of willow bark was salicylin. But it wasn't until Hoffmann synthesized the aspirin that we really had the first prototype anti-inflammatory drug, which actually lasted for nearly 50 years, till almost the end of the Second World War. And it was only after that all the other anti-inflammatory drugs were synthesized, like ibuprofen, naproxen, and so on. Along with this time, there was this young physicist called Wilhelm Röntgen in Germany who discovered X-rays. Now, X-rays would come to play a very important role in our understanding of rheumatoid arthritis and the structural damage it does. He won the Nobel Prize for Physics in 1901. Around that time, of course, we had Renoir, one of the standard bearers of the Impressionist movement, who was crippled with rheumatoid arthritis. And one can only speculate whether he had the benefit of aspirin. But he was really struggling, and he had to have his paintbrushes tied to his hands in order to paint these wonderful masterpieces. So there you can see the deformities of rheumatoid arthritis in Renoir's hand. Whilst on the topic of X-rays, I will jump forwards, and just to give you some flavor of how our understanding of radiological damage in rheumatoid evolved. There were a number of various scoring systems, starting with Larson. The Ritchie Index came from Glasgow, where I used to work in the mid-90s at the Glasgow Royal Infirmary. And of course, we have Sharp, and more recently, the van der Heide variation of Sharp indexes. And later on, we'll come to other imaging technologies. The treatment of rheumatoid arthritis was quite empiric. And this is an article in the British Medical Journal by Frank Dudley Hart, who was one of the leading rheumatologists in the 70s and 80s in London. And as you can see, it's an alphabet soup of various things. And we know that some of these even exist now. But going back to the non-steroidal anti-inflammatory drugs, the next major step was this. Sir John Vane actually came from Birmingham, but his work was in London, and he espoused the COX-1, COX-2 hypothesis, which was the next important step forward in the evolution of our understanding of anti-inflammatory drugs. And that led to his Nobel Prize in 1973, and perhaps the first designer drug meant to obliterate the bad COX, which is the COX-2, and give us an anti-inflammatory drug without the gastrointestinal side effects of the non-selective non-steroidals. And that led to the launch in the late 1990s of two drugs, celecoxib and rofecoxib, which were hailed as the best thing since sliced bread, and the use of these coxibs rose exponentially till it came to light the cardiovascular toxicity, and then the bottom fell out of the coxib market, and rofecoxib, of course, was withdrawn, and celecoxib and etoricoxib still remain, but its use has certainly declined over the years. So here we go in terms of the action of these coxib, which target the COX-2 inducible prostaglandins, but keeps the COX-1 constitutive prostaglandins intact. So in terms of the evolution of non-steroidal use, as you can see, there was this uptake and upsurge of use of COX-2 selective drugs. This led to the increased use of non-steroidals, but then in around 2004, 2005, the cardiovascular risks and even the renal risks of indiscriminate use of non-steroidals came to light, and that led to the waning of the anti-inflammatory drugs and increased use in opioids. And as we know that the OxyContin story is where the increased use of opioids led to a whole nation of dependence, primarily in America, but also in the rest of the world. So the next act is disease-modifying anti-rheumatic drugs, or DMARDs, as we rheumatologists like to call it, and corticosteroids. And one of the poster boys of rheumatoid arthritis in the mid-50s, who had, unfortunately, career-limiting rheumatoid arthritis, was the heart surgeon Christian Barnard from South Africa, who performed the first cardiac transplant. What are DMARDs? It is what it says on the tin, disease-modifying anti-rheumatic drugs. And other than symptom control, they are thought to also modify the course of the disease. And there was a whole glut of different drugs, ranging from the 1930s to the late 1970s, starting with sulfasalazine. This is Nana Schwartz, who was a member of the Swedish Academy, which awarded the Nobel Prize in Medicine. Then we had Plaquenil, or hydroxychloroquine, which was an improvement on chloroquine sulfate. And of course, the game changer was prednisolone, which was synthesized by Hench and his colleagues at the Mayo Clinic in Rochester, Minnesota in the late 1940s, and he won the Nobel Prize in 1951, which is probably the fastest turnaround of discovery and the Nobel Prize in the history of the Nobel Prize in Medicine. And finally, of course, there is what is still the anchor drug for rheumatoid arthritis, methotrexate. So these are the three Nobel laureates who won the prize for the discovery of steroids, and its use in inflammatory arthritis. In the center is Philip Hench. And then we go on to methotrexate. Now, methotrexate has an interesting background. It was synthesized in the Lederle labs by a very bright Indian scientist who went off to America to work in the States. His name was Subbarao, and he was the first person to synthesize methotrexate. Methotrexate started life as an anti-cancer drug, and it was used in childhood leukemias by a pediatrician hematologist called Sidney Farber. You may have heard of the Dana-Farber Institute in Boston. And there is a fascinating book called The Emperor of All Maladies by another Indian called Siddhartha Mukherjee, which charts the social history of cancer. But its use in rheumatoid arthritis and other rheumatic diseases started in the late 60s, but the first significant double-blind trial of methotrexate was published in the mid-1980s, in 1985, by Michael Weinblatt from Boston, and the rest, as they say, is history. It became firmly entrenched in our armamentarium as the significant drug that we all use even today. One other important development in the 1960s was the first prosthetic hip joint in 1961 in Wrightington Hospital, which is in Lancashire, by Sir John Charnley, and this was followed by knee joint replacements in the United States, and they helped patients with terminal destructive disease to regain a modicum of mobility and life. So we are now well into the mid-80s, and we have this sort of repertoire of conventional disease-modifying drugs with methotrexate, sulfasalazine, which is still around, hydroxychloroquine, leflunomide. Gold was extensively used, as was other drugs like D-penicillamine, cyclosporine, azathioprine, some in combination. Quite often, these combinations caused unacceptable side effects. And despite all this, we were not really making a huge impact on the natural history of rheumatoid arthritis. And it was quite an empirical approach. It depended on individual biases of the clinicians, the patient's preferences. There was widespread concern that methotrexate was an anti-cancer drug, and many patients refused to have methotrexate in the early 90s. I well remember that. And this is what happened. We were still, this is a slide, this picture is from Ian, and this is what still happened. we were unable to make any significant impact on the natural course of the disease. And as Hamlet would say, to be or not to be, or in other words, well, what do we do? And if you are still cross with Britain for having left the EU, you can have Rhoda and the Thinker. Take your pick. So there was this real need for us to reevaluate how best to deal with the problem of rheumatoid arthritis. And a number of different strands came together throughout the mid-80s to the early 90s. We understood the natural history and epidemiology of rheumatoid arthritis better. Rheumatoid arthritis was not just a disease of joints, but actually had an impact on mortality. And that was work that came from Ted Pincus, Fred Wolf in the United States. Clinical trials were more sophisticated. Arthritis organizations came into being. We had these registers, which was following the introduction of biologics. Regulatory bodies in the UK, like NICE, would then determine what drugs we could use under what circumstances. Diagnostics improved. So this was a dawn of a new era in our thinking and approach to rheumatoid arthritis between the mid-1980s to the late 1990s and early noughties. And obviously, there were huge strides in the drugs available to us. So throughout the 80s, there was a shift away from how we thought about rheumatoid arthritis. Ted Pincus in Nashville, Tennessee, and Jim Fries in California, they began to publish data that suggested that mortality rates in rheumatoid arthritis with severe disease were much higher than the normal population. And even survival was comparable to stage 2 Hodgkin's disease and 3-vessel coronary artery disease. So this was not just a joint disease, but a systemic disease that had a real impact on people's lives. So till then, our treatment aims were to reduce pain, disability, improve quality of life if we could, and hopefully retard disease progression and improve prognosis. But even with those aims, we could not really make a huge impact on the disease itself. This was what was the traditional model of treating rheumatoid, the pyramid, and people got fed up with it, and there was an increasing chorus of voices from both sides of the Atlantic suggesting that we should leave the pyramids to the Egyptians and then change our approach and be more aggressive in our approach to treating rheumatoid with the drugs we had at our disposal. And some of the major trials looked at how we could change our approach. So there was this step-up approach, the step-down approach, the combination approach, and these are some of the key trials that I think defined the 90s till the advent of the biologics. So here we go, combination, early intervention, aggressive therapy, inversion of the pyramid, and so on. In parallel, something else also happened. Hitherto, we had been so dependent on X-ray damage, but it was soon realized by the time the X-ray erosions for rheumatoid happened, the horses had fled the stable. We were a bit late. And therefore, something else came to the rescue of the rheumatologists. And it was pioneered by Professor Ian Donnell, who was also in Glasgow in the 1950s. And he had pioneered the use of medical ultrasound in obstetrics. And we adopted ultrasound as a diagnostic tool. And now, of course, as you have seen from Professor Rednick's, the ultrasound courses are across the world, and it is an indispensable tool for rheumatologists to diagnose early arthritis, to diagnose active inflammation and damage far more accurately than X-rays can. So this, as well as the MRI scan, they gave us a lot of different tools to look at the disease more carefully, to pick up inflammation much more early than X-rays could. We also began to unravel the soup that was the inflammatory synovial fluid. Knowledge of immunology led us a better understanding of the cells, the molecules, the cytokines, and that led to targeted therapies for the first time in history. And we also became aware of the various elements that led to an undifferentiated arthritis to develop into what we call rheumatoid arthritis. So, in the late 90s, the trial started, which ushered in the revolution in the treatment of rheumatoid arthritis. And if you think of aspirin as a bicycle, the monoclonal antibody is like an A380 super jumbo. And these are the two people who led the charge. On the left is Professor Sir Mark Feldman, and on the right is Professor Ravinder Maini, both from the Kennedy Institute in Charing Cross Hospital in London, and they were the first to trial anti-TNF, infliximab in this case, and the rest, as they say, is history. We also have Professor Joe Edwards from UCL in London to thank for his seminal work on anti-B-cell therapies. Obviously, B-cell therapies were already in use in lymphoma, but he was the first person to use it in rheumatoid arthritis. And although Professors Feldman and Maini did not win the Nobel Prize, they did win the Lasker Prize, which is called the American version of the Nobel Prize. So these are the two landmark papers that ushered in the biologics age, and by 1999-2000, infliximab and etanercept were launched, and we had come a long way from the days of aspirin. So over the next few years, there were developments which led to increasing numbers of various kinds of biologics and modification of the anti-TNF molecules, as well as targets to anti-IL-6 and abatacept. So there was this paradigm shift. Now that we had the tools, we could now think of how best we could deal with these difficult problems that weren't responding to conventional treatment. And the birth of the treat-to-target concept emerged, and that has now been the dictum or the altar at which we all bow. At least we try and achieve this. It's not always easy, as you well know, but that is so. We took a leaf out of oncology, and we then said treat aggressively, remission induction, and remission maintenance. So a whole range of combination treatments came into play with methotrexate plus or minus steroids, which were used far more creatively than in the past to try and achieve this treat-to-target concept. And then we had more understanding of how undifferentiated arthritis progresses, all the various influences that can lead to the progression from undifferentiated arthritis to established inflammatory arthritis or to remission. And we have now increasing insights about the pathology, and there is a huge amount of work that is now going on to try and hopefully personalize our approach on an individual basis, and to try and, the holy grail of course, is to prevent it from happening. So the newest kid on the block, of course, are the JAK inhibitors, as you well know, and there's been a lot of sessions on JAKs, quite rightly, and we have this whole range of different JAKs, and more are coming on stream. The initial enthusiasm is slightly tempered by some of the cardiovascular risks with tofacitinib, but I'm sure it represents a significant step forward in terms of oral treatments that are as good as biologic treatments and are less expensive. So to summarize the evolution of rheumatoid arthritis, we've gone from bed rest and whiskey to JAK inhibitors and biologics. And it's been a long journey, but a very fruitful one. I remember the days when we had a ward of 24, 25 people who'd be admitted regularly, who'd get their steroid infusions and then march down to the therapy pool by our physiotherapists, and they would come every so often. In England, very few rheumatology units now have inpatient beds dedicated to our patients. If we have any patients, we usually borrow from our general medical colleagues. And the other important thing is the age of biosimilars. Biologics were great, but they were expensive. So this has ushered in a new age which allows better access for countries that would not have been able to afford these biologics when they were under patent. And final act of this play, if you like, is where are you marching or where are you going? What about the future? Prevention, of course, is the holy grail, and personalized medicine is what we are striving for. So we need effective treatments which are affordable and cost-effective. We cannot escape that. We need meaningful, measurable outcomes. DAS28 has served us well, but it is still, we have to evolve into better ways of measuring disease and remission and low disease activity. We need to have drugs that have good risk-benefit trade-offs, and we need to make sure that we are cognizant of the patient's personal choice. So these are some of the things that are in the pipeline, and of course, there has been increasing interest about the microbiome in everything, certainly in autoimmune diseases. The role of the metabolic syndrome is becoming more and more important. We are beginning to understand how best to use biologics and tapering, and we've also had some lessons from the pandemic about how to deliver care more optimally without necessarily bringing patients back so often. So remote consultations and other ways of providing good care have developed as a result of the COVID pandemic. So it is time to pause and think, ladies and gentlemen. We know we have made great progress since aspirin was produced in 1897, but many challenges remain. It's about predicting outcome, individualizing care, and it all comes at a cost to the individual, cost to society. Equity of access still remains an issue, and we still have to be careful in balancing risks and benefits, and it's not always easy. So lastly, the last couple of slides, we must always keep the patient front and center. This is about 10, 12 years ago. One of my patients who'd been with me for 10 years, I casually said to her once that, Mrs. So-and-so, I do understand what you're suffering. And she said, Dr. Chaudhuri, I like you very much. You've been my doctor for 10 years, but do not presume to think you understand what I'm suffering. You have no idea what I have to go through till you have walked in my shoes. And that has for me been a very sobering realization that we have to keep our patients in mind all the time and not get too swayed by the scientific advances we make. And finally, these are my two favorite quotes of all time. The first, of course, is first do no harm. So whatever new drugs come our way, use it with circumspection and with care. And William Osler, who started life in Canada, then spent time at Johns Hopkins and retired as the Regius Professor of Medicine at Oxford, said, the good physician treats the disease, the great physician treats the patient who has the disease, and I firmly believe all rheumatologists, no matter where they are great physicians, and you should take pride in that. Thank you very much.